hate to say let's go into the future because the present is pretty darn good.
Right, the present is
Let's take a look at some of the new maintenance strategies, induction strategies. Who wants to start us off talking about the most recent switch maintenance trials? Who wants to do that?
I can
Please
talk about some of these studies. So the strategy for switch is this. If your viral load is undetectable and you have no resistance, you can switch to almost any other, even modestly effective combination, and the switch will work. So, for example, there's a combination, Paul mentioned rilpivirine, FTC, and TAF, and there have been a couple of new studies with that particular combination. Rilpivirine is not a drug that we would use in somebody whose baseline viral load was greater than 100,000 copies, or whose CD4 counts were less than 200. But if you look at people whose viral loads are undetectable on tenofovir FTC efavirenz, or on the older formulation of tenofovir FTC rilpivirine, and you switch them to TAF FTC rilpivirine, they maintain virologic suppression just as effectively as if you continued them on their previous therapy. So I think that kind of study is just representative of all of the switch studies. If you're virologically suppressed and there's no history of resistance, you can switch almost ad lib to any other effective combination.
And I think the controversy really is when you're, I totally agree with what Ian says. There's some, where you see risk in a switch is where someone is on a kind of a high barrier drug like a boosted protease inhibitor, and you don't know their kind of resistance history, and then you switch them to a lower barrier like a NNRTI, for example, or even some of the integrase like elvitegravir or raltegravir. There's some risk there, but there are no studies like that because the companies don't want to do that kind of risky stuff in studies. What's happening, I think, is there's also kind of this kind of de-intensification. Like, can we go down to 2 drugs?
Okay.
And then there are even some studies going down to 1 drug, and I think those are kind of on the edge in some respects. And Paul,
yeah, I mean, my thoughts on the 2 drug, especially when one of the 2 drugs is a protease inhibitor and the other one's lamivudine, is that there are now enough randomized data that you could take someone from boosted protease inhibitor plus 2 nucleosides and switch them to boosted protease inhibitor plus lamivudine or emtricitabine, and they will maintain suppression just fine. That was done in the darunavir study that was just presented in Glasgow, and it was been done in the atazanavir
Just so that we
study.
recognize what these studies are. There's the switch from TDF to TAF containing ART study.
Yeah, no brainer, right? No brainer.
Yeah,
No
those
brainer.
are all
No
fine.
brainer.
The dual Jacida 8014 study.
Works fine.
Right.
Yeah.
That's what Paul is talking
That's
about.
what you were talking
So
about.
basically simplifying from boosted PI and 2 nukes to boosted PI and our best tolerated nuke, which is 3TC or FTC.
Yeah.
And while there's the most recent one was with darunavir, there's ones with lopinavir, there's ones with atazanavir. There's a ton of data.
They all work.
It works.
And then there's the, am I pronouncing this right, Domino study or Domino study?
Yeah.
What is that?
I'm not so keen on that one.
Tell me about it.
Well, that's just using dolutegravir, which I've alluded to, which I think is our best integrase inhibitor, as the sole treatment for people who are virologically suppressed. And it's not as if that is necessarily giving them any benefit except for only maybe saving money. I mean, I don't
There's
see
just no compelling reason to do it.
I just don't see the reason to do it, and it's also that some of the studies there's been a little bit of virologic rebound and problems.
Well, in that study, I think, it gets reported as non-inferior, but I think if you look at that data carefully,
it's inferior.
It looks
they
inferior.
have a crazy endpoint, which is a viral load of 200 for people who have been suppressed forever. That's not the right
less than
endpoint.
50. And if you look at the less than 50 data, people are not being maintained at the same rate of suppression if they're on dolutegravir monotherapy.
We did this with protease inhibitors. We tried the monotherapy approach, and it didn't really work. And I don't think it's going to work.
It just didn't work quite as well.
Right.
Right.
The same thing is probably going to be true with this. So you'd have to have a really good reason to do it.
Right.
But do
And
you
it's
realize
hard
what
to
you're all
think of
saying?
one.
I mean, you're talking about it's really good or really, really good.
Right.
If we got one of these 20 years ago, You'd
Sure,
be
of course, it'd
doing
be a different story,
Absolutely.
sure.
Right.
Sure.
But
This
you know, you can't mess up with HIV because HIV will become resistant.
Right,
And
and
it
you
will
don't
limit
have
your
an infinite
options.
number of choices.
Yeah.
You have lots of choices, and you
So-
can rescue most people. But if you kind of start blowing your integrase inhibitor, you know, you're going down a slippery slope that you don't need
So
to go down.
why,
There's just
why
no
do
reason.
that? These studies, these abbreviated regimens, the studies are basically coming out of Europe. And the reason is cost is a much greater consideration for the choice of regimens in Europe than in the United States. And in our country, fortunately, we still have a healthcare system that is willing to pay for these medications. I think it is a huge mistake to try to shave the number of drugs down to the fewest number, the smallest number that is going to be effective, you know.
You have to have a better reason than just saving money.
Yes.
If there's a potential risk. And there are risks. You know, a lot of people have done these avant-garde type switches and they've blown up in their face. So I think we have to be careful. When we originally did the boosted PI lamivudine studies, it was because there was a compelling reason to try to avoid tenofovir and abacavir in a subset of people. We don't have that as compelling a reason now as we used to.
All right. And again, correct me if I'm wrong, when you say they're expensive, the therapies that we're using, it's really expensive to get a population of people with rebound and lots of virus and then everything explodes. It's not just the cost of the drugs here that we're talking about.
Yeah.
I mean, HIV therapy does stand the test of cost effectiveness because the benefits, the health benefits are so huge. So even at their relatively high cost.
You were talking about cost per year of
Yeah,
life, and
yeah.
that's really where the answer is. And for society too, right? Even an expensive therapy, if you prevent the spread of this virus, then there's all, I don't want to use the word herd immunity because it's not right, but you do keep the virus contained.
Definitely.
And that's different, and that's important, isn't
Yeah,
it?
I mean, it's been projected that if you have enough people virologically suppressed, the epidemic will eventually end. You know, that could happen.